My name is Ashley, and we're going to talk about a current quality control issue at a facility I work at dealing with specimen collection. The following is what I will be covering today during this presentation. The quality issue I'd like to discuss is the instance of lost, mislabeled, or destroyed specimens within the main OR. When an error of this nature occurs, it requires a patient safety report to be generated and requires further investigation by the department. Once the investigations were conducted, the evidence showed that 80% of the cases were directly related to ineffective communication and handoff among staff members. Specimen errors are significant for patients because it requires a need for additional invasive procedures, delay in patient care, or even the inability to diagnose and develop a treatment plan. Oftentimes, a specimen is surgically collected to rule out a diagnosis of cancer, which means there's typically a suspicious mass that is removed in its entirety and studied. So, for example, if we see a breast mass and the breast mass is removed and then lost, mislabeled, or destroyed, there's typically no more mass in the patient's body that can replace that missing or destroyed specimen. However, if the patient does have multiple sites that a specimen can be collected from, this means additional surgical procedures. Rosenthal estimates that to run an operating room in the United States, it's $62 a minute. Let's take a breast biopsy, for instance. A breast biopsy is estimated to take anywhere from 10 to 60 minutes. So if we translate that into a financial impact on the facility, 62 minutes times 10 to 60 minutes, that's $620 to $3,720 for that operating room time. Now, if a patient is returning to the operating room due to an error within the facility, such as a lost or destroyed specimen, this means that the procedure is done twice, and that cost due to the error is the hospital's responsibility to pay. So you can see that lost, mislabeled, or destroyed specimen is significant for the patient as well as the facility itself. Once it was identified that 80% of the errors were related to communication among the staff members, the facility decided to do some communication interventions. First off, they did mass education for all the main operating room staff, and then they developed a rainbow sheet, which we'll go into further shortly. And ultimately, the goal is to decrease the number of lost specimen, and they're going to track that through the patient safety data. So whenever the error is made, they have to do a patient safety report, or a PSR. So they're going to track that data, and then they're going to compare any PSRs that come through with the rainbow sheets and make sure that the rainbow sheets were done properly, and if there was still an error and the rainbow sheets were done properly, investigate further what the main source in the issue was. The mass education within the OR was just to re-educate and reinforce the proper process for specimen collection. So the proper process is that the doctor in the case, once they identify a specimen, they will announce it and they'll tell the staff what they want it to be called and how they want it to be sent, whether it's fresh, frozen, or permanent. Then the surgical tech will place the specimen on the sterile field, and then the nurse creates the proper label on the proper container. Then they'll remove that from the sterile field, and then the nurse will enter the data into the electronic medical record and print the order sheet. Then the nurse is to take the specimen to a designated area in the OR and place the order sheet within the proper book. And then pathology will come up and retrieve the specimen at some point throughout the shift. Or if it's a fresh or frozen specimen, a runner from the OR will be sent to deliver the specimen. The rainbow sheet was created to help with the effective communication within the OR. There's 4 sections: the sign-in, timeout, confirmatory timeout, and then the team debrief. For this specific case of specimen, that will focus on the team debrief, which happens at the end of the case. As you can see in blue, the specimen is appropriately labeled and accounted for. So prior to anybody leaving the room, it's a step where we verify that the proper specimen is in the proper container with the proper name, and the proper label, and that it's going to be sent to the proper location. Anything that changed didn't take overnight. However, the response has been pretty positive in the long run, because the rainbow sheets are actually being done and the surgeons are taking responsibility and verifying that their specimen are done correctly. And then the education piece made the team more aware of the process and the errors that were occurring, and when you're more aware of what is occurring and why, it helps you prevent doing that in your own practice. However, the department isn't 100% free of the errors, and a couple things have been identified as part of the process issue, to include pathology being unaware of specimens that are left in the designated areas, and then sometimes the printed sheets that we create are being misplaced. After reviewing the literature, I found 3 really great recommendations. The first recommendation was a color-coded label system. So as fresh, frozen, and permanent specimen had a different color label and a different color biohazard bag to truly identify the type of specimen and help prevent the destruction of that specimen. The second recommendation I found was the use of a master terminology list. So in this study, the GYN department got together and the doctors created a master list that they all agreed on of what they would call specific specimens. So each doctor used the same name for the same type of specimen, rather than each doctor calling the specimen something slightly different. This allowed the nurse to have a drop-down menu when labeling specimen in the medical record and prevented errors that way. The last recommendation was a barcode system. So the nurse would scan themselves, they would scan a patient label, and then they'd scan the container that they were going to place the specimen in, which would create a pop-up window on the medical record. They would type in the name of the specimen the doctor requested, and then they would print that label, which made the label all digital versus handwritten portions of it. Then it would also send a alert down to pathology that there was a specimen on its way, and it gave the pathology department more ownership and visibility of where the specimens were in the process and where they were coming from. Nurse leaders have a lot of responsibility when it comes to ensuring we're doing what's best for our patients. And that's not always easy, and it's a continuous job. Porter and O'Grady actually talk about this cycle of vulnerability, which actually translates really well into making change. As nurse leaders, the cycle of vulnerability starts with just becoming vulnerable and open to new ideas, and then choosing to take a risk that challenges the status quo. So if we don't think what we're doing currently is the best, take the next step and challenge it. And then we stretch our organization. So we basically push our organization and the people we work with to look beyond what they're currently doing. And then we live the new capacity. So if we're making a change, we live that new change, and then we evaluate the outcomes of that change. And then we course correct as needed. We know that some of the best ideas on papers, once we actually implement them into practice, are not 100% wonderful. So being able to recognize that and course correct as needed as we're doing it is important. And then cherish the results of new knowledge. Porter and O'Grady say that leaders should always document both positive and negative results, and use that and positive to really learn lessons from what we've done. And then we begin the cycle again. Anything that's a cycle is continuous. So we can, as leaders, just continually strive to be that leader that's vulnerable and open to new ideas. Guidelines from the American Nurses Association can assist nurse leaders as they work through change within their unit. There's 3 I'd like to particularly focus on. The first is coordination. Change doesn't just happen overnight. It takes teamwork, and it takes being able to communicate and be transparent for there to be buy-in for whatever you're trying to do. So coordinating with others is important. Standard 12 ethics. Anytime we want to do something new, we need to ask ourselves, is this ethical? Is this what's best for our patients? And then if we have questions, being able to participate on multidisciplinary, interdisciplinary teams as a checks and balances is very helpful and useful as we work through change. And then standard 13, research. All the change should be evidence-based, and being a leader that supports an environment with sufficient resources for research and scholarly inquiry to really promote change that's evidence-based is critical. When we think of change, a lot of times I think we also think of conflict around change and resistance to change. And change can be difficult, but it doesn't have to be completely miserable. And 2 Timothy 2:24 said, "And the Lord's servant must not be quarrelsome, but kind to everyone, able to teach, patiently enduring evil." So as nurse leaders, as we implement change, I think we need to be able to teach and really show the benefit of what we're trying to change, and then be patient, because people aren't going to instantaneously gravitate always to change. But in the long run, if we're patient and kind and able to teach and show the benefits, eventually the change should be easily integrated and eventually accepted. In conclusion, we discussed the current quality issue of specimen collection within a facility, with the interventions that were made to correct the issue, the responses to those, and then maybe some future recommendations for that facility, as well as the role of the nurse leader and what the American Nurses Association and the Bible has to say about being a leader during change. Any questions in regards to this presentation, I'd be happy to answer. You can reach me at akrestuccio@liberty.edu.